Welcome to today's webinar. Our topic for today is best practices to clean and disinfect senior living facilities in the COVID-19 environment. My name is Megan Klein and I will facilitate our event. Please note, the information contained in this presentation is intended to provide general information, but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Our webinar today will be presented in 4 distinct sections by our 3 experts, Dr. Katie Morales, Jeremiah Gray, and Dr. Julie Mangino. Stay tuned after the question and answer portion to learn more about how direct supply can support you. Our first segment on environmental transmission, the pathogen journey between the hospital and extended care facilities, will be presented by Dr. Katie Morales. Dr. Morales is currently an associate professor at the University of West Georgia. She received her PhD from Georgia Baptist College of Nursing of Mercer University. Her dissertation research was a mixed methods feasibility study which tested the effect of a resident-focused hand hygiene intervention in a long-term care facility. Dr. Morales has over 30 years experience as a registered nurse. Her practice areas include adult medical and surgical, orthopedics, emergency department, and intensive care. Dr. Morales is a contributor to 5 books, Legal Nurse Consulting, Principles and Practice, the Emergency Nursing Bible, the NCLEX RN Review, Keeping It Real Simplified, and Nursing Made Easy, along with Pharmacology Made Easy. And now, to begin our webinar today, please welcome Dr. Katie Morales.
Thank you, Megan. I have 3 objectives for my portion of the presentation, and they're on the screen, so I will not read them to you. But we'll see if I can cover all these points in my allotted time. So when we think about all the settings that people receive care in nowadays, we have ambulatory surgical centers, end-stage renal disease facilities, acute care hospitals, which typically the average length of stay is 5 to 6 days, and then in acute care, acute long-term care, which would be more than 25 days. We're going to talk about long-term care facilities. And in my study that I did, the mean length of stay was 951 days. So we're looking at roughly 3 years, right? So it's a long time. And each of these settings are hyperlinked. So you could click on that and see some infection prevention strategies specific to each setting if you'd like. But when we talk about long-term care facilities, we have several challenges. One is there's limited human capital and equipment available in most of these facilities. They may lack specialized infection control staff. Long-term care facilities by nature promote socialization of the residents there. They typically have semi-private rooms and may lack isolation rooms. So when you look at the headlines right now with COVID going through the long-term care, these are some of the challenges that the long-term care facilities have faced. And when we think about who's at risk, it's always our 2 ends of the spectrum, right? The very young and the very old. So that is an issue. I can't see my screen because the camera's on it, but I know the next topic is immunocompromised. And this could be someone with long-term comorbidities such as diabetes or asthma, or someone that's on steroids long-term. A prolonged length of stay would increase your risk. And we just shared that in my study alone, it was 3 years length of stay in a long-term care facility. Any indwelling medical device provides that portal of entry, as does impaired skin integrity. So any break in the skin. Poor respiratory or hand hygiene, and we'll look at both of those. And then overuse of antibiotics increases our risk. So when we look at preventing infection in any setting, really, we want to look at an interdisciplinary team collaboration. And following the One Health model, this is where we think about animals, environment, and humans and how they all interact, and it's one health. So you can look over on the left side of the screen and see all the different departments that we would involve in a healthcare setting. So dietary, of course, nursing, medical services, infection. Some that you might not think of, the very last one, pet therapy. So I just had a student who did his honors thesis on the role of pet therapy dogs that visited the local hospital, and he cultured the dogs before and after they made their rounds just to see how many pathogens were found on the coat of the animal. So just thinking about, should we be offering hand hygiene before and after somebody pets the dog? Thinking about these things. So let's just talk about what the definitions are. When we talk about healthcare associated infections, these are infections that someone receives while receiving treatment for some other issue within a healthcare setting. And of course, hospital is an acute care institution offering inpatient care. And long-term care facilities are institutions that provide care to a resident who cannot manage independently in the community. Some people call these nursing homes. When we talk about respiratory hygiene, this is coughing or sneezing into the elbow or covering the cough or sneeze with something other than a bare hand. And then, of course, we got to talk about T-zone touching. So anytime you touch your eyes, nose, or mouth, you potentially could inoculate yourself with a pathogen that's on your hand. When we look at nursing homes in particular, or long-term care facilities, the types of infections that we could see include the respiratory viruses or pathogens, urinary tract, GI tract, skin and soft tissue, which could include pressure ulcers, scabies, conjunctivitis, bloodborne pathogens, and don't forget sexually transmitted diseases could also be there. And then what I like to call the alphabet soup, any of the multi-drug resistant organisms that are known by their acronyms, such as MRSA, VRE, ESBL. So any of these multi-drug resistant organisms can be transmitted in a long-term care setting as well. So why do we care about healthcare associated infections? Well, they're pretty serious. Annually, this is according to World Health, and it was not dated, but I referenced it 3 years ago. So I'm sure that a newer version will be coming out with even more staggering numbers. But at that time, this represented 1.7 million infections annually with 99,000 associated deaths, including unnecessary hospital readmissions. And in the U.S. alone, that was $28 to $45 billion with a B annually. So it's a large loss of health, life, and money. So I did do a mixed method study, so I had quantitative and qualitative data. So I removed the identifying information, but mine was conducted in a long-term care facility. It was rural in the southeast U.S., and it was associated, at the top is a picture of the long-term care facility, and at the bottom is a hospital that was associated with that facility. So they both had about 100 beds each. And I started with field observation. So the first day of the study, I went and watched in the dining hall to see how many residents performed pre-meal hand hygiene, and then how many performed correct respiratory hygiene in the dining hall, and then how many times they touched their T-zone. And so what I've done is highlighted the outliers for you, and you can see the highest pre-meal hand hygiene was on day one, when people were not sure who the stranger was that was watching them. So it's a little bit of a Hawthorne effect, I think. They were not sure who was watching, and they were, on their best behavior kind of thing. So that highest was 55%, and the least amount of hand hygiene was on the last day when they were more accustomed to me, and that was 25%. It's staggering to me. This was done during cold and flu season that year, and none of the respiratory hygiene met the definition I gave you, either coughing or sneezing into the elbow or using something other than the bare hand. And then if you look at how many times they had an opportunity to perform respiratory hygiene, it went from 42 to 110 episodes of coughing or sneezing in one meal. And then the T-zone touching, the highest, I believe, is 53. Again, I can't see because of this camera. It's hiding it for me. Let me see if I can hide it real quick. Anyway, some factors I didn't think about that would affect T-zone touching. was a history of dry eyes or using nasal cannula oxygen. So that immediately made the residents want to touch. It's so simple. I see you shaking your head, Julia. It seems so logical, but it totally skipped my attention until I dug a little deeper. So thank you. Okay, so the qualitative findings, I found 7 categories. I'm only going to discuss 6, and we'll look at each one individually. So the first theme that I found was susceptibility to infection. None of the participants, which were residents and staff at the nursing home, recognized this population as inherently at risk for infection. One of the staff participants said, "How do residents get infections if they never leave the facility?" And then residents and staff possessed a false sense of protection, leading to the misconception that no other action was needed on their part. Some said there was less risk for infection in the facility due to all the infection control measures that were taken. And then one participant said, "You've got everything here to protect it, to keep from getting infections." So they totally did not see this population as a risk of infection, which was interesting because I had developed a tool called the Risk for Healthcare Associated Infections, which looked at measured risk factors identified in the literature with a range of scores from 0 to 12, higher scores indicating greater risk for infection. I had expert review obtained before I used the tool. And while neither residents nor staff participants recognized the population as inherently at risk for increased infection, the mean score for the sample was 7, with a range of scores from 4 to 10. So again, if 12 was the highest, we had people with a score of 10 that still didn't think they were increased risk for infection. The next thing, which is certainly very popular now, when I did this, people weren't talking about social distancing like they do now, was social exposure or social distancing. And this is increased risk of exposure from others. There was awareness of cross-contamination from objects that were touched by multiple hands, however. And some residents would say they shouldn't come in the dining hall when they're sick. So they recognize the need to isolate people who are symptomatic. And this was just in general, not any specific disease. While staff participants promoted social distancing for the residents, they admitted to personally working while sick. So one staff participant with a past medical history of C. diff said, "I kept working until I couldn't." So this was an employee that, for whatever reason, felt burdened to have to report to work with C. diff infection. The next theme that emerged was seriousness of infection. And this is a factor where if they had a personal history of infection, healthcare-associated infection, they saw it as much more serious. And if they had no history, they didn't see it as serious. So there was a lack of knowledge. One participant said no one died or went to the hospital during the recent flu outbreak in the facility. So you're hearing people say that now during the pandemic. You know, we're measuring it by how many die or go to the hospital instead of how many are infected. Participants without prior experience of infection tended to think of infections as a less serious risk. One resident said infections are a real bad inconvenience, and another resident said, "I think infections are a pain in the neck, frankly." Some of the barriers that I identified to hand hygiene varied. So reasons for suboptimal hand hygiene, one resident said, "I don't have no wipes." So their perception was there was no way for them to clean their hands. Whereas a staff participant said, "You've got wipes all over the place." So there was definitely a misconnection there between the availability of hand hygiene supplies. Then we looked at cues to action. So this would be either a verbal, handing somebody a wipe and saying, "Here's a wipe to clean your hands," or even nonverbal if it was laying on the table when they arrived in the dining hall. Verbal, as I mentioned, and one staff participant said, "How can they forget?" Actually, this was a resident that said this. "How can they forget when the girl is standing there? Here, wipe your hands. How can they forget?" So this resident was frustrated that other residents were not cleaning their hands. Staff were mixed about who should be responsible for initiating hand hygiene. However, residents indicated either verbal and visual cues would be helpful overall, so they appreciated a reminder. The next thing was lack of personal accountability or self-efficacy. And this was interesting that both staff and residents viewed others as at risk for and sources of infection. And they viewed others in need of hygiene. In fact, if they arrived and found a wet wipe on the table to clean their hands, if you did not tell them it was to clean their hands, they would clean the table. So they viewed the environment as needing cleaning. You also didn't hear people, neither the residents nor the staff, speak in the first person. It was, you spread germs, you should not come to work sick, you should. So it never was it a personal message. So rather than taking responsibility for controlling infections, residents expressed a sense of protection in the facility, which may contribute to belief no action was required on the residents' part. So when we look at infection, we have to think about the portal of exit. How are the germs exiting, right? And this is where the respiratory hygiene was so very important. And then as a medical provider or healthcare provider, we have to think about anytime we're performing aerosol generating medical procedures that we need to take precautions for ourselves. And then another mode of exit, which is not respiratory, of course, would include incontinence, which we certainly see a good bit of that in long-term care. So to prevent infection, looking at the mode of transmission, we have the World Health Organization's 5 moments of hand hygiene. We know that the highest risk for contamination is when performing activities of daily living, which is often performed or assisted with in the long-term care by healthcare workers. So we're looking at everybody involved, the healthcare worker, the patient or resident, visitors, pet therapy, and the environment and equipment, which the other speakers will present on much more. Then we look at the portal of entry. So once the germ is out there, how's it going to infect a person? And this is often through the invasive therapies that we offer, either IV or central lines, ventilators, urinary catheters, or drains. It can be surgical sites or open wounds. So think about the elderly people have such fragile skin, and you could pull a Band-Aid off, could rip their skin pretty badly. And then the portal of entry. So we want to make sure we're limiting invasive therapies and removing anything invasive as soon as possible and limiting the T-zone touching. So there was a video not too long ago where the director of the CDC was talking about avoiding T-zone touching, and then she licked her fingers and turned the page, and it became viral. While it was somewhat humorous, I would just challenge you to monitor how much you touch your T-zone. We are all so guilty of this. It's pretty bad. And then thankfully, we have prevention bundles. We have the surgical site infection bundle, the CLABS through the central line acquired bloodstream infection bundle, and the catheter acquired urinary tract infection bundles. And these are hyperlinks that will take you to those bundles if you'd like to look at them. One thing I will point out on this slide is I see this little sponge right here. I will just tell you that most of these kits contain chlorhexidine, and I'm one of the few people on the planet that is allergic to it. So always ask if the person is allergic to chlorhexidine. And then how do we prevent infection? By removing that susceptible host, so the vaccinations. And if this is a hyperlink to the most recent vaccination schedule, including here are the healthcare personnel vaccinations that are recommended that we have as healthcare professionals. We do have a lot of regulatory compliance, so we want to make sure we're completing surveillance, epidemiology, and reporting. The challenge is that here in the United States, states have different criteria for reporting HAI, so we're not always comparing apples to apples. And again, here are some hyperlinks to take you to some resources for you if you're interested in learning more about that. So when we have a plan, we want to make sure we can have a plan to actively detect and isolate people who are under investigation for whatever pathogen we think they might have. And then we want to have targeted interventions specific to the facility. If we know that there's limited resources, it won't do any good to develop a plan that's resource rich for a facility that doesn't have all those options. We want to bring everybody we can involved into planning. So occupational health, if that can help people master the coughing into the elbow, educating our staff and residents about respiratory and hand hygiene and avoiding that T-zone touching. Chlorhexidine has certainly been very effective in several studies. And again, I just caution you to check allergies first. Vaccination of both the staff and residents, and then your antimicrobial stewardship. So here are two hyperlinks. and the bottom one is specific to nursing homes. Here are several resources available to you. They're all free online, and these are hyperlinked to it, so you can just click on it and it'll take you straight to it. The last thing I'm going to mention is emergency and disaster preparedness, which this was done long before COVID-19 happened, so it's kind of interesting that it was thinking about it. But thinking about prompt detection and triaging people that we, whether it's flu pandemic or epidemic, just local to your area, whatever it might be, and then isolating the people that you are under investigation. Hopefully you have negative pressure room, but if not, a private room, or getting a mask on the patient. So whatever resource is your best resource, getting those in place right away. Contacting your local health authority and doing the reporting that's required. Screening visitors and limiting visitation, which we're seeing some effect of that social strain of that. I'd love to hear comments from some of our participants. Since we do promote socialization at the time that we're limiting visitation, how do we adapt for that and provide that social stimulation to our residents? And then make sure that we're providing instructions to healthcare providers. I know some of the frustration with the COVID-19 was that frontline healthcare workers didn't always feel like they had clear direction of what was really required of them. So here are my references, and I will hold any questions till the end. And I think, Megan, you're going to take over again.
Yes, thank you so much, Dr. Morales, for that great presentation. Our second segment is going to start now with Jeremiah. And our second segment is on the building blocks and best practices of cleaning and disinfection. And this is in combination with the third section of our presentation, titled The Advancements in Spraying Technology and Chemistry on How to Evaluate Disinfectants versus Sanitizers versus Cleaners. Since EarthSafe's inception in 2014, Jeremiah Gray has led the development of safer, more sustainable chemistries, pioneered disruptive electrostatic spray technologies, and forged numerous innovative programs in the healthcare, education, and cleaning spaces. Under Jeremiah's leadership and guidance, EarthSafe developed the Evaclean infection prevention system, which has since become the leading authority on healthier disinfection. As a longtime supporter of environmental causes, Jeremiah leveraged a career in green technologies-based financial management and private equity to create new investment platforms built around social responsibility. And now, to continue our webinar today, please help me welcome Jeremiah Gray.
Everybody, hello. I'm happy to have the opportunity to present to everyone today. I'm looking at the attendee list, and it's quite substantial. So I hope you guys derive a lot of value from this afternoon, and that our real world experience in the field, working with numerous nursing homes, healthcare institutions, as well as other industries over the past 4 years or 5 years since we've launched this program, it can bring a lot of value to what you guys are looking at in terms of solutions for not just COVID-19 and the unprecedented scenario that we're in right now, but future initiatives and continuing focus on sustainable and predictable results of your infection program going forward. The first part of this presentation today is really a nice segue from the initial presentation you guys just saw, and it's very, very well done, and I think really topical. We developed Evaclean, which is a branded infection prevention system around some innovative best-of-breed technologies, what we feel are some of the safest and most effective chemistries out there in the marketplace, but really with a focus on pulling together all the disjointed pieces in current cleaning and disinfection protocols that sometimes do not work as synergistically with one another as they need to. And really focusing on the entire process from a 10,000-foot view. So the the goal of our company with these programs from day one has really been to focus on what are the existing resources that are in place in facilities today, right now. Like I mentioned, we work in healthcare quite often, both in the acute care space as well as many long-term care facilities. But we also work with a number of industries right now where the need is great for far greater or more enhanced cleaning and disinfection protocols, but the budgets that are afforded to these protocols are not necessarily increasing proportionally. And I think that's probably a universal common theme that we see across all industries, yours included. So we always try to make our focus from a consultative standpoint on taking a look at the existing resources. What do you have in terms of staff? What's the available budget that you guys can allocate for proper cleaning and disinfection? Based on some of the standards that have been set and established by the Joint Commission, and which have been proven to be highly effective when they can be properly implemented. How can we best utilize the staff and other resources that we have to get as close to compliance to that standard as we possibly can? So our company mission and ethos has always been, really designing a future where technology empowers, not replaces, the people that are tasked with the critical role of protecting our public health. We've had phenomenal experiences and quite a lot of direct interaction and work with some amazing EVS teams and housekeeping staff across every industry throughout the years. And one thing that we continuously find is that people understand the importance of their role. They understand the benefits of doing their jobs correctly, and they understand the risks associated with not following protocols or not adhering to best practices and standards. And quite honestly, when we identify what the sources of non-compliance or some protocols that aren't operating as well as they should be, it's not necessarily from a lack of enthusiasm or focus or interest in doing the right thing. It's simply a lack of time and available resources. So our goal with these programs has really been to deliver technologies to take a look at existing IPC and really optimize that, identify latent inefficiencies, and better deploy that time and resources so that you guys can be as effective and preventative as possible in mitigating and controlling outbreaks, whether that be COVID, norovirus, MRSA, or any number of other pathogens that you guys might encounter on a day-to-day basis within your facilities. So on that line, the company goals have really always been to establish best practice standards for efficiency during cleaning and environmental sanitation. Efficiency is going to be a common theme you hear me talk about all the time today. We sell equipment, we sell chemistry, but it's often that 5-10 minutes into an hour-long presentation, I'll largely talk about those things as commodities in many respects. The world doesn't necessarily need more chemicals, especially even in this COVID-19 environment. It hasn't necessarily been an excuse to blanket the entire world in chemicals, and I'm sure we'll have plenty of case studies and interesting data to come out from these various countries that have been fogging entire cities with these cannons of disinfectants and what the environmental risks and exposure and outcomes are going to be with that. It really has been to leverage technology to become more efficient, and there's no real science or complexity to proper cleaning and disinfection. The challenge that we always continually try to address is how do we do it more frequently? How do we do it more comprehensively? And how do we do it with higher level compliance than what we're typically used to on a day-to-day basis right now? One of the ways that we can do that is by streamlining and simplifying not only the processes, but the amount of equipment, the chemicals, the training guidelines and procedures from both an efficacy standpoint as well as a safety standpoint that people need to be trained on a regular basis. So there's definitely opportunities for us to eliminate unnecessary or redundant chemicals in cleaning and disinfection processes. and standardize around more universal chemicals that achieve exactly what you're looking to do without the unnecessary variation and complexity in the process. One of those chemicals that we'll talk about today, and you've probably all had exposure and experience to it, and I'm sure quite a few of you use it within your facilities. So, please don't let this be controversial. I get some eye rolling when we talk about one of our goals being the removal of quaternary compounds or quats from a lot of facilities, but we do find that, especially in today's day and age, where cleaning and disinfection is happening much more frequently, we need to focus not just on how effective these chemicals are, but also any potential long-term environmental exposure risks that may be associated with more frequent and heavy usage of these chemicals as they accumulate on the surfaces. And that's one category of chemistry that we have identified as potentially problematic in this new era of much more enhanced and frequent disinfection of a wider range of surfaces throughout facilities. From a training perspective, I think we're in a new era, but we're also in an industry that, compared to some others, is slow to catch up or embrace new technologies. And especially within this sector, it's a high turnover industry where there's plenty of limitations or barriers towards achieving compliance levels to get to where we want them to be. And one of those is, education gaps, language gaps, the continuous high turnover rate that's associated with this profession. That makes training quite a difficult thing. So there are ways through virtual reality trainings, online media, QR codes, things like that we can be more frequent in our continuing education efforts, and we can ensure better compliance and more sustainable compliance across, the entire staff, regardless of tenure or experience. And lastly, from a validation standpoint, I think that's what the industry has been sorely missing, and what we've identified over the past 3 to 4 years as a critical piece of being able to continuously improve these program outcomes is we need to track. I mean, you need to collect data. You can't make any actionable decisions on how to improve processes without proper data to support that. So whether it's through, some very simplistic, basic means like the use of ATP swabbing, which is an okay method of assessing cleaning effectiveness, all the way through some of the rapid culturing programs for, collection of swab cultures on the surface that can validate the effectiveness of your sanitation efforts. Being able to implement these in a proactive and economical fashion, which does exist today, is really key to you guys measuring over the course of a year whether or not the efforts you're making on this front are achieving the goals that you set for yourself, or whether or not it's deficient in certain areas. And at least with knowledge of where you need improvement, you can target those specific areas, and you can become much more focused on how to improve it both quickly and inexpensively. So just to give some validation to everything that we're talking about here and account for the lack of PhD at the end of my name, we have some of the top teaching institutions and most credible thought leaders in the industry that have tested this, have validated our program both from an equipment, chemical, as well as process standpoint, and have all delivered fantastic results. Tufts Medical Center, NYU, which we'll mention a little later on in the presentation, have done clinical efficacy studies on the effectiveness of electrostatic disinfection, as well as standardization of their processes and protocols, and have continuously produced outcomes that are dramatically better than what they had done previous to them implementing Evaclean wide scale across their facilities. Kaiser Permanente is in the process on a national scale of implementing. As you guys know, that's one of the largest IDNs in the country. Cleveland Clinic has done various efficacy studies on electrostatic disinfection specifically. And to anyone at 5-Star Senior Living and Jack Kelleher, if he's on the call right now, I don't know if they had a crystal ball pre-COVID, but they were the first large-scale installation of the Evaclean program that we had nationally. And to their benefit, they really had this program up and running at every single one of their facilities and were ready to go as soon as the first COVID outbreak hit. So they've been a phenomenal proponent, very proactive and forward thinking on this, and have given us a lot of great data to further validate the effectiveness of these programs when they're implemented and done correctly. You've been bombarded with COVID-19 stats over the year or over the past couple of months. So I'm trying not to hit anybody with things you see in the media on a daily basis. But I think in terms of mortality rates and what the risk is, you should all be well aware that we're not talking about the risk associated with a beach in Florida opening up prematurely, or people going out to the bars in Texas right now. Within this sector, the risks associated with not having proper prevention measures in place are exponentially higher. The breakdown by demographic compared to flu, where the 65 plus demographic is still far more susceptible to death from flu than the majority of the rest of the population. We see those numbers increase exponentially over 30% in the highest risk demographics for COVID-19. And with the resurgences that we're seeing across the country right now, that becomes critically important. The multiple modes of transmission, and now we have the World Health Organization evaluating a lot of data that supports the fact that this virus is completely airborne now, further emphasize the need for us to have as complete and proactive of an infection prevention protocol in place to mitigate the risk associated with transmission of this virus from multiple different vectors. So the technology that we use here in the Evaclean program is really two parts. We have an electrostatic spraying system technology that really has achieved quite a bit of limelight and exposure in the media and press over the past couple months, but has existed for decades in numerous industries. Ghostbusters looking backpack you see on the right-hand side and the Stormtrooper Star Wars looking device on the left. What that is a mechanical spray device that employs a technology called electrostatics, which magnetically charges the droplets. So when we dissolve a pure tab into tap water, we pour that into the handheld sprayer on the left-hand side. Compared to a normal trigger spray bottle where when we spray the surface, it just coats the top side of a remote control, or you may get the tabletop easily with a microfiber rag. The likelihood that you're going to get 100% coverage in all the nooks and crannies and surfaces that fingers touch but don't frequently get cleaned, that poses a huge issue for standard cleaning programs. Whereas when you magnetically charge these droplets, you could create an attraction between the disinfectant and the surface that you're spraying or trying to disinfect. So if you can use the example of a wheelchair, for instance, electrostatic disinfection of a wheelchair, which takes roughly 15 to 20 seconds, will get full coverage across that surface, all the spokes, all the areas of the wheels, the tires, the small spots that would take a tremendous amount of time to physically wipe down, can be very rapidly and effectively disinfected using this technology. And at the strength that we're approved on the EPA list N for this chemistry, it will kill COVID-19 without a pre-clean. That's very important to understand on the surface in just 1 minute. So it's become one of the most effective and most commonly used frontline defense systems out there for prevention of surface transmission and high-level disinfection during this COVID outbreak. What you can see here, just with that QR code right in the middle of the screen, to the point on training, this has become extremely valuable technology recently from a training standpoint. So those QR codes, you open up the standard camera app on your Android or your iPhone, you can point it at that, and it'll automatically pull up a hyperlink. That hyperlink can be changed and tagged to whatever we want. So if it happens to be a specific training video for your facility on proper use of the chemistry or the equipment, if it's a PDF that pulls up a single page on best practices and protocols and such, we can make that accessible to every single user out there. So plenty of people will have that printed out on laminated cards in the chemical closet. They sometimes will have it in a little, laminated key ring on the housekeeping carts. But basically, giving people access at their fingertips to all the training materials they would need, or refreshers are the goal of that technology. And it's very, very effective when deployed properly. So we talk about the most valuable assets that people have at their disposal. And the goal of this discussion is not to ask anyone to really necessarily spend an extra dime on improving their cleaning process outcomes. It's about how do we better utilize these most valuable resources we already have available to us, make them more efficient, give them tools that allow them to do their jobs more effectively and efficiently. And use that time saved to better deploy elsewhere. And we get a lot of positive feedback to this approach because if you walk the floors of many trade shows over the past couple of years, you see robots and all of these various things that can be effective when deployed correctly. But they're met with some hesitancy that, like anything else, people feel that they're going to be replaced as a result of automation, and that really is not the case. The goal of technology should be to make everybody's lives easier, make them more effective, but not replace them. So this is really the crux of what we focus on here. It's limited resources require more resourcefulness, and if we just distill down to its most basic, what we think the most finite resources we have available to us right now are their time, their budget, and their last one can be coined as mind share or focus, or people's ability to learn the vast amount of safety and protocols and processes they need to understand and properly maintain a program across your facility. So if we can better utilize time, we can implement more efficient protocols to unlock that time. We can better deploy that time elsewhere. Without people's budgets increasing exponentially over the next 12 months, our goal is to enable 50 to 100% more cleaning, more disinfection within your existing budget constraints to allow you to do more with less. And lastly, through standardization and simplification, take this simple multiplication table right here and dramatically pare that down. So as opposed to 10, 15, 20 different processes associated with cleaning and disinfection, really streamline it around 2 or 3. That can accomplish up to 99% of what you need to do in every one of your facilities, which is definitely achievable, practical, and what we've done in many of our installations. I hope this works for everyone, but I just wanted to show how simple the use of this type of technology is, and you don't need a trained expert to do it. We've put this in the hands of housekeepers with 30 years of experience that are resistant to change, and within 5 minutes they're off to the races and they're having a great time disinfecting, which is a strange way to put things in our industry, but it's the truth. People actually they enjoy using it. They enjoy the simplicity of it all. And on the conversely, I have a 5-year-old son who is able to disinfect our house using that same technology. So what we're doing is really bridging the gap in experience. It's a simple solution where you fill the tank up, you click the tank on, you turn the electrostatic on, you point 2 feet from the surface, pull the trigger and spray. And at that point, the technology takes over, and that wrapped magnetic effect that you get attracting to the surface gets far, far greater, more enhanced coverage with disinfectants than what you're typically able to achieve using a standard wipe or microfiber program. What you see here is a facility down in Bethesda, Maryland. This is one of Kaiser Permanente's medical office buildings in their infusion center here. And they do this process at the end of every single day. A couple things to note in this video is that, again, it's a touchless disinfection approach. So for COVID-19, it does not require pre-clean on the surface, only visible soil. Secondly, based on the SDS sheet and the safety profile for our pure taps chemistry, it does not require a respirator or a mask to use. That's not to say that everyone shouldn't already be using masks as a universal precautionary measure from transmission of the virus, but it does go a long way in terms of highlighting the safety of the actual chemistry itself when using it in a spray device like the Protexis sprayers. So it makes it extremely easy and simplistic for them to go at the end of every single day and fully disinfect those areas in far, far less time than it would take with an abrasive cleaning and disinfection program on its own. So to sum it all up, the Evaclean program is really a complete, standardized, and scalable approach to infection prevention, rather than 8 to 10 different vendors all having to piece together the puzzle pieces to put your program together. This covers everything from cleaning, disinfection, floor cleaning and disinfection, all the way through high-level disinfection using electrostatic spraying technology, all based around one universal chemistry in a highly efficient and highly effective process that's been validated and vetted out through 12 to 18 months of clinical efficacy studies and data collection to be one of the fastest and most effective frontline defenses against infection transmission in your facilities. Now, I'm going to go on the assumption, and you guys can correct me in the Q&A if I'm off base, but our sprayers and electrostatic sprayers in general, since the start of this outbreak, have been widely publicized in the media. You may have seen them used and deployed throughout Delta Airlines for all of their airplanes. The hospitality sector, numerous cleaning and disinfection companies that have embraced this. The global demand for this technology has been astronomical. Part of the reason, again, being that it's such a simple disinfection method, but what's being missed, and I think where the regulations are going to really come into play and cut out some of the players that have opportunistically jumped on the bandwagon, so to speak, over the past couple months, is that there's a lot of considerations that need to go into making sure that these protocols are not only effective, but they're also safe. So when we set out to develop the Evaclean program around this spray technology, the first criteria that we knew we needed to meet was we need to be able to do everything with one universal chemistry. Giving people the option of mixing and matching and choosing any number of 100 different labels or chemicals to put through devices like this that have the ability to apply 10 times the amount of chemicals in a facility comes with some responsibilities to ensure safe use. So before the first implementation of Evaclean ever happened, we made sure that we did all the requisite testing. We had an approved chemical solution with NADCC, which from a hypochlorous acid standpoint is one of the most universal and effective chemistries out there for cleaning and disinfection. We made sure that we had the ability to quantify the results through swab culturing and data collection. We did all of the testing data for OSHA and NIOSH compliance. So this involves air quality analysis, both for the worker themselves while they're doing the spraying, cumulative exposure testing over an 8-hour time period, as well as exposure for room occupants. We did exposure testing with occupants that were 5 feet away as we were spraying, just to make sure that all the levels presented no inhalation risks, and they all fell well below the permissible levels and limits set by OSHA and NIOSH. So we have high marks for safety. Chemical equivalency data, making sure the electrostatic charge does not modify the chemical in any way. These are all things that people that have rushed to embrace this technology, put it out there in the marketplace, ignorant of what chemical they put through it, are overlooking. But it's something that the EPA is looking very closely at. And lastly, and probably most importantly, is environmental exposure risks. So what are the implications of continuous disinfection, residual accumulation of chemicals on the surface after the fact, and any kind of environmental health or safety issues that may come up with exposure to that chemical. So that's one of the reasons that quats, for instance, were pointed out in the beginning as a chemistry that's not really effective for electrostatic disinfection, certainly, but high level and frequent use the way that we need to in today's climate. So all of these things, if you don't have them in place, would be red flags. And it's important when you select a program like this to go with one that's been tested and vetted and doesn't have any variability associated with it. Because you can imagine from a compliance standpoint, if people had the ability to do what they wanted in every single facility out there, there's too much change. There's too many variables that could impact the outcomes, that there's no way for us to ensure consistent compliance and predictable outcomes and results. With a method like this, where it's universal, whether there's 5 people or 5,000 people using it, the ability to achieve that compliance you're looking for becomes exponentially easier. So from a process summary standpoint, it's very basic. We have a chemistry called Pure 1, which is based around NADCC, which we'll explain on the next slide. But essentially, it's our cleaning and our disinfection chemistry. It has surfactant base, so it's a highly effective cleaner and disinfectant with that same 1-minute kill claim on COVID-19, as well as a 4-minute kill claim against C. diff, which used to be the dominating discussion topic until February of this year, but still highly effective against that as well. And other emerging pathogen threats that you guys have probably dealt with, like Candida auris and some of the other things too. This would be used with any existing microfiber program, with your floor cleaning and disinfection program, as well as a dry wipes solution, which has been a very attractive option over the past couple of years to reduce cross-contamination risks associated with launderable microfiber. You can mix up a Pure 1 solution, pour it over top of a dry wipes system, and now have a very effective disposable wipes program that eliminates the cross-contamination risks associated with normal microfiber. For the enhanced surface disinfection, we implement the electrostatic technology, and this is really our ability to take the 50 or 75% of surfaces that can't be touched or disinfected using standard cleaning protocols and achieve proper disinfection on all the ones that we normally would miss. And again, that's using the spray technology, whether in the backpack or handheld form, combined with our Pure Tabs chemistry, which has really the same efficacy claims as Pure 1, except it doesn't include a surfactant, which allows us to do a touchless approach on a surface without the need to wipe it off afterwards. I wanted to include just a study. This is related to the Cleveland Clinic, and Curtis Donsky has done a lot of fantastic studies over the years focused on C. diff and sporicidal disinfectants, but more recently has focused on electrostatic disinfection as one of the most effective technologies for us to bridge the gap on all the areas, again, that we're missing with standard cleaning protocols. With the CDC estimating that up to 50% of room surfaces being left completely untouched in a typical terminal clean, and these are in acute care facilities where the standards for cleaning should be at the highest. That still is a massive problem. So how do we get to the 50% of additional surfaces that aren't touched? Curtis Donsky, he evaluated the application of a sporicidal grade disinfectant, which used hypochlorous acid like our Pure Tabs, with a wiping method versus electrostatic disinfection with no pre-clean. What he found was that they saw a proportional reduction in the amount of C. diff spores on surfaces, but using the electrostatic method, it required only a quarter of the time of application compared to having to physically wipe across every single one of those surfaces. So it was a fantastic validation of the technology. And it really highlighted, a lot of questions that people had regarding whether or not, this was as effective of a method as physically wiping surfaces. And in all of his tests and studies, he showed that there really is nothing lost in the electrostatic process versus the physical cleaning process. So this is really the focus and part of the presentation on the chemistry piece itself. We find that, again, as you walk the trade show floor as an example, there are thousands of chemistries out there and chemicals that get pushed on people on a regular basis. Yet at the end of the day, there are only really 10 or 12 base chemistry formulations that comprise the majority of the cleaner and disinfection market. When you narrow it down to that and you look at, the efficacy of those 12 or 13 different chemical categories, now you can get granular and you can take a look at some very specific things. One, obviously, it's got to be incredibly broad spectrum. So with any DCC, when we dissolve it in a normal tap water, it creates hypochlorous acid, which is a very, very flexible, broad spectrum disinfectant with efficacy on par of a normal bleach solution, for instance. But two very, very important and significant differences. One is that our pH is near the pH of your skin. It's between 6 and 7.0 in diluted form, whereas straight chlorine bleach has a pH of 12 to 13. It's the reason that we have a 000 safety profile, which is the safest profile for chemical disinfectants out there, compared to bleach, which is far more corrosive to not just surfaces, but also dangerous to people handling it and using it. It also means, again, that we have far greater surface compatibility. So in a spray application where we're going to be hitting all methods and kinds of surfaces, it's important that we had very, very good surface compatibility to ensure that in the process of disinfecting a larger area of your facility, you're also not causing concerns regarding damaged equipment or jeopardizing the safety of the personnel. And on top of all that, being a tablet it really comes with some significant benefits. Storage and the footprint that it takes to bring on 25 gallons or 50 gallons of solution is really the size of a large peanut butter jar. So we're no longer worried about storing liquid concentrates or ready-to-use chemicals that can not only be much more expensive, but also have a shorter shelf life. We have 3 years of stability on a tablet before it's mixed. So in today's day and age where supply chain issues have been a concern, and I think everyone is going to go into 2021 and the rest of 2020 trying to make sure that we're looking 90 to 180 days out and making sure that we've adequate supplies of chemicals for anything that's to come down the pike in the future. This is chemistry that you can bring on hand, you can have available to you, and you don't have to worry about expiring within a short time frame. So it really is a fantastic option for that. Again, it's highly, highly efficacious, while at the same time being one of the most economical chemistries that exists out there in the market. And again, that NFPA rating, the 000 in use dilution, is the best that you can get out there in the marketplace. So we've felt that in terms of a universal broad spectrum disinfectant that can tackle everything from C. diff all the way down through being an NSF certified D2, which means food contact surface safe sanitizer with a no rinse, no wipe claim. This accomplished everything we need to do 99% of what your facility would have to do from a cleaning and disinfection standpoint. This is a slide that you guys will have available to you after the fact. But again, it further emphasizes the fact that this chemistry is compared to your straight chlorine bleach or some of the more commonly used sporicidal chemistries like peracetic acid and an oxycide product from Ecolab, for instance, are not only some of the most efficacious, but we do so at half the concentration of chlorine bleach. We're far less corrosive. We're much, much safer, and we exhibit much better surface and material compatibility than the majority of comparable options out there. So we do feel that this is not only the most economical and safest, but also the most effective choice for your cleaning protocols. Early on, and when Megan was introducing me, she talked about my financial background, and we always try to focus on investment strategies for our customers that focused on sustainability. And while we are in the business of selling and offering chemicals, we want to make sure we do so in the most responsible way possible. And we felt that by embracing a tablet technology, not only are we reducing, the shipping and storage expense, but we're also not incurring, all the hazards and environmental risks associated with transporting water all across the world. With simple tap water and 4 tablets per gallon, we can mix up all of your needs for disinfection on a daily basis. And it's, again, as simple as counting out the right amount of tablets, dropping it into the tap water, letting it sit for 5 minutes, and now you have your proper disinfection solution. It couldn't be any easier. And when you consider it as an alternative to some of the dilution control stations, chemical mixing systems that you have in your closets, which can have anywhere between 20 or 30% range of concentration every time you press that button. And that's been validated time and time again. This is the most accurate and effective way for you to ensure the right concentration, the right quality solutions, and simplicity of your programs and protocols on a day-to-day basis. Lastly on this, no program exists successfully without all the proper documentation, and again, training is such a critical element of making sure that we have good and proper compliance around these best practices. They're only as good as people's compliance to it. So we've continuously developed this, and we'll continue to source new ideas and feedback from the market on what the most effective means are on us achieving this. But you see an example there on the left-hand side of a recommendation that was made by Kaiser Permanente on building out small little laminated guides that could go on a lanyard that people wear around their neck on a day-to-day basis. And on one side, they have proper dilution guidelines for the chemical. Sometimes on the other side, they have just your quick little 1, 2, 3 step checklist on how to effectively disinfect using the electrostatic technology, and they have it available on them at all times. The QR codes, again, on the right-hand side can be specific for whatever your needs are. So we're continuously developing this. And again, we have quite a bit of feedback that we get from the staff on a regular basis that quite often gets implemented into our future training materials and all of our guides. The last piece I'll discuss here is on the quat piece specifically. This is something that we feel very strongly about, and especially in today's day and age where we're no longer just cleaning on a regular basis. We're cleaning and disinfecting with sometimes 10 times the frequency that we were pre-COVID. With that extraordinary increase in use of chemicals and disinfectants comes a need for us to focus much more closely on chemical compatibilities, and more importantly, incompatibilities. We've had many issues and plenty of feedback, across other industries that are now implementing disinfection protocols where, you get somebody that takes a grout cleaner at the end of the day when they're trying to clean off their floors in the kitchen, and they inadvertently mix it with bleach, which obviously is a reaction that nobody wants to have. Quaternary ammonium compounds, or quats, fall into the same category. So we want to make sure that in the evaluation of our future protocols, we identify any potential incompatibilities, and we can replace or at least streamline it so that every chemical you use for cleaning and disinfection in your facility is compatible with one another, and you don't run any kind of health and safety risks by using them. Quats can also limit the amount of disinfection that you can do in a facility. So if I talk about floor disinfection, which has a lot of data to support that should be part of any protocol. They're not an effective chemistry to do so. It leaves a sticky residue on surfaces. It can accumulate and build up over time, and it could damage floor finishes. So, for the versatility of these chemicals and their widespread use, because they were relatively cheap chemistry to implement in the past, they also come with a number of limitations, I think, that are more important than ever. Not to mention the fact that they're non-sporicidal. They don't kill a lot of the emerging pathogens like a Candida auris, for instance. And they certainly have better options and alternatives that exist out there. What some people might not know is that quat binding is an issue that we see happen time and time again, but there's quite a lack of awareness as to what that actually is. For anybody using launderable microfiber, quite often when they're using a quat like a Virex 256 or something like that, What you'll find is that microfiber is a double-edged sword. It's a very effective cleaning technology or material, but it also exhibits this interaction with quats, where the actual active ingredient, the quaternary ammonium salt compounds, will bind to the fibers themselves when they're saturated with it. What that means is that when you actually go to wipe across the surface and apply the chemical to that surface, very little of the active ingredient, as you can see in the chart on the right, after just several minutes of exposure, is transmitted to the surface. So if you needed an 800 ppm solution starting out of quat to be effective per the kill claims on the master label, after just 5 minutes of saturation on that cloth, 50% of that quaternary compound has bound to the fibers themselves and is actually not released to the surface. Several minutes later, the cleaning solution or disinfection solution is really just as effective as water itself. So it's a very, very prevalent, persistent issue with quite a lack of awareness as to this happening in a number of facilities that utilize quats on a very, very regular basis. But it's something that can dramatically impact the results of your infection prevention programs if you're not disinfecting properly and you're not aware of this phenomenon that happens. So I'll go through this very quickly, but Pure Tabs is essentially the exact same efficacy claims as the Pure 1 product we discussed before, but without the introduction of the surfactant. So it's strictly meant for electrostatic disinfection. It can be done for a number of different pathogens without requiring a pre-clean on the surface. The only situations where you still require the surface to be pre-cleaned every time is for C. diff and for bloodborne pathogens, but everything else can be electrostatically disinfected without reducing the efficacy of the solution. And lastly, this is just an example of some of the training materials and guidelines that we do for implementation of the electrostatic technology. So, proper stickering and secondary labeling is important for any vessel that you would pour disinfectant chemical into. We make sure that that's provided for any spray technology that you guys utilize for application of disinfectants, with the opportunity to date it, check the proper amount of solution, as well as clear instruction guides in a number of different languages to make sure that whatever your protocol calls for, we're achieving that each and every time, and it's extremely simplistic and easy to use from a user standpoint. Just give an example of a program that we've implemented. This isn't an acute care center, but I thought it was relevant because it talks about the wide scale use. And I wanted to throw NYU in there because I speak with them on a weekly basis. And the head of epidemiology is not only a huge proponent of hypochlorous acid, but also one of the more progressive thought leaders out there on electrostatic technology. NYU utilizes our full suite of chemistry, the entire Evaclean system, wide scale across all three of their major medical centers, and have further expanded to their satellite locations in Brooklyn and Long Island throughout the COVID outbreak. But it's the most full and wide scale implementation of our program that exists for the longest amount of time. They've done a tremendous amount of data collection around this as well. So the good thing is that before New York became the epicenter for COVID-19 and all the outbreaks, this was fully implemented in all of their facilities, and they were able to further enhance their disinfection protocols using the technology they already had in place. One thing that we did create, and we learned a lot throughout the due diligence process, is that we have a number of calculators and means for us to fairly accurately assess what your consumption is going to be, predict that on a monthly, quarterly, and annual basis, and really give you guys a good understanding and an idea of what it actually would take to implement a program like this wide scale throughout your facilities. So rather than a wait and see approach and let's see what the outcome is, we can give you confidence and assurance that whether you're in the budgeting process right now for next year or whether you're trying to fit this into an existing budget, we understand that when the protocols are followed correctly, exactly what the consumption could be, and we can do a job costing analysis fairly accurately for you. Lastly, on this a clinical study, efficacy study that NYU did. And I'm running along on time here, so I'm going to breeze through it real fast. But essentially, what Dr. Phillips there did was evaluated their results, and they continue to collect data to support the effectiveness of this program. They were planning on announcing the results of the FSHEA conference this year in March, which we were excited about, and subsequently, a bit upset when it got canceled. But what was extremely notable from the preliminary results that they shared with us were that compared to just a simple cleaning and disinfection method using a standard microfiber cleaning and disinfection process, when they implemented the electrostatic technology and the NADCC on top of it, they found a tenth of the number of colonies on 5 key touch points in a blind study in every single room where they implemented Evaclean compared to their standard cleaning and disinfection protocols. This was done through swab culturing, so it was done very specifically, not using ATP or things that would have quite a bit of variability in the outcome and the results. So we're very reassured and confident that in a facility like NYU, this has been validated at the highest level to work very effectively. And the very last slide I have here, Tufts Medical Center, as I mentioned in the beginning, was one of the first adopters of our program. They implemented a very similar program as NYU. They wanted to get rid of chlorine bleach, which is something they had been using wide scale throughout the facility and standardize around one chemistry. They've replaced quats that had been used pretty wide scale and a number of other chemicals that were no longer necessary when implementing the NADCC program. They also added the addition of floor disinfection as well as the electrostatic piece to make a very comprehensive cleaning and disinfection protocol. When they started this out prior to Evaclean, their standardized infection rate, which gets reported to CMS on an annual basis, was 2.0. Far from the national average and really not in good territory. The implications from both a human health and safety risk standpoint as well as a financial standpoint are high when you're in that level. When we last got the update from them in October 2019, prior to COVID, their standardized infection rate had dropped to 0.1. We're one of 6 factors, but a very significant contributing factor to that reduction and dramatic reduction. And they were very proud to tell us that unprecedented in the history of the hospital, they were actually at that time, they had reduced C. diff infections substantially and had actually gone 75 plus days with 0 infections, which had never happened before in the history of record keeping at the hospital. So that's the end of the slides. I hope you guys got a lot out of this. I know it was a lot to digest in a short time frame, but in the Q&A, I'm happy to answer questions. I just hope you guys understand that this is a program that is fairly new. It's technology that's fairly new to the marketplace, but it is very well vetted, validated, and has all the proper data to support it. So any installation and implementation we do of this is always going to be somewhat unique to your facility. But we have a lot of past precedent and a lot of prior experience on ways to successfully implement this that we can very effectively help you project manage the implementation of any kind of system or program that you would want and need in your facilities. And really function as a partner in that effort as opposed to a simple vendor. So thank you everyone for your time and attention.
Tons of jam-packed information in there. To finish out our educational webinar today with a segment titled The Developments in Applications of UV Light and Their Role in Today's Cleaning Environment, do please welcome Dr. Julie Mangino. Dr. Mangino is Professor Emeritus at The Ohio State University and The Ohio State University Wexner Medical Center in Columbus, Ohio. Her research interests include the prevention and control of healthcare-associated infections. She was the medical director of clinical epidemiology at the hospital as the hospital epidemiologist and worked with the antimicrobial stewardship program for more than 20 years. She has focused her career on the prevention of HAIs. She was the lead author on the OSUMC guideline for the diagnosis, management, and prevention of C. diff. She has performed research on environmental cleaning and ultraviolet disinfection to augment room cleaning and continues interest in this area. She spent 2 years on the Society of Healthcare Epidemiology of America Education Committee and authored an online course for ID fellows for the prevention and management of all potentially transmissible organisms. She has spent 25 years as an academic ID clinician in both inpatient and outpatient settings, mentoring students, residents, fellows, nurses, and pharmacists, and she continues to work in the ambulatory venue, primarily teaching ID fellows. She has over 70 publications, is a fellow in both FSHEA and IDSA. Based on education, research, committees she has led and/or served on for the last 20 years. She received her medical degree from the State University of New York Downstate Medical Center in Brooklyn, New York, completed her internal medicine residency and infectious diseases fellowship at the University of Alabama, Birmingham. She received the OSU Department of Internal Medicine Earl Metz Award, of which only one is chosen per year, in April of 2017. And she has been in Best Doctors in America every year since 2005. And now, to complete our educational webinar today, please welcome Dr. Julie Mangino.
My objectives, which follow with Dr. Morales and Dr. Gray, with respect to healthcare-associated infections. Important to realize patients acquire organisms from the hands of the healthcare worker and the environment. The MDROs, multi-drug resistant organisms, have been listed in the other presentations as well, so you are aware of them. I'm going to talk about why we need more than conventional cleaning and share the history of ultraviolet germicidal irradiation, a long name, and how it's being studied and used in healthcare today. And it's important to realize a multifaceted approach to decrease HAIs via hand hygiene, isolation, environmental cleaning, disinfection, and antimicrobial stewardship are really the most important points. In this graphic, a table that shows the effect of the colonization or infection status of the prior room occupant on the acquisition of pathogens by subsequent occupants or victims, I could say, of the same room. So on the vertical, we have the publications. The authors in this table looked at VRE, Abomanii, MRSA or VRE, and C. diff. And if we go to the right side and look at the hazard ratios or odds ratios, anything consistently over 1 is significant. Net, there were significant findings if the previous occupant had C. diff for the current occupant to potentially acquire C. diff. Why is that so? Because there are many problems associated with conventional cleaning and disinfection. A lot has been talked about today about the different products and the rationale for the products. Again, some products work on some surfaces and some pathogens are affected by that product and others are not. There are also problems with cleaning and disinfection procedures with results dependent really on the housekeeper or the environmental services person following the directions on the protocols so that they are used according to manufacturers' recommendations. In this study, I'll orient you to the graphic. This is percent on the vertical, time on the horizontal. we looked at direct observations. These are real-time observations of housekeepers who are actually being observed while they are cleaning the patient's room. So there have been consents by each of the persons to be observed. And you can see that over time, 29% of the surfaces were addressed adequately. In yellow, attempted but inadequately. Purple is wrong solution, and not attempted or ignored was in red. And over time, we did better. We did not get to 100%. In year 5, in rooms that did not have an observer, we did pre-cleaning fluorescent markers and then post-cleaning confirmation with the fluorescent markers. And about 64% of the surfaces were appropriately cleaned. In year 5, we also did cultures of the rooms, particularly focusing on the C. difficile rooms. Pre-cleaning, 23% were positive, and post-cleaning, 8% were positive. So bottom line is, to get to adequate cleaning takes a lot of time, a lot of effort, and we realized that, you know, augmented forms of cleaning were in line. So in the next graphic, you can see that we had UV set number 1 early on, and reflecting the standardized infection ratio, 1 or below is where you want to be. For C. difficile, this is healthcare associated C. diff. The second set was implemented, and then the third set was implemented in 2017. And you can see we had really and truly with the third set of emitters, we had our best C. diff rates. Next slide, you can see that we increased our time of use of the surface side ultraviolet emitters over that time frame as well. So, next slide. The infections in long-term care facilities are definitely not unlike those that are in the acute care facility. There are many guidelines and there are many outbreaks discussing those multi-drug resistant organisms that have been associated with the outbreaks. And there are very definitive guidelines for use in long-term care facilities. Next slide. When we look at environmental cleaning, it's important that the personnel who are in charge of the cleaning have job-specific training and competency validations, are audited, and the facility provides feedback to personnel regarding the quality of their cleaning. When we look at the next slide, when we look at HAIs and MDRO surveillance and infection prevention practices, surveillance cultures are becoming less and less prominent. So this is a survey in 2013, followed up, same survey in 2018, and the third column is increase expected and a decrease expected. So actually doing more surveillance cultures is not going to be increased over time. Next slide. When we look at environmental cleaning, however, we can see increases are expected in 2019 with visual monitoring, ATP detection, UV markers, as I shared in our study, as well as adjuncts with UV disinfection and potentially hydrogen peroxide vapor mist. Next slide. How does ultraviolet light work? Ultraviolet is part of an electromagnetic spectrum. It's divided into 3 regions: UVA, longer wavelength, UVB, shorter than that. UVB is solar UV light, and then UVC, 280 to 100 nanometers. So this is shorter wavelength, however, much more active and more important for biologically damaging and killing microbes. So you can see the sweet spot here for the UVC, somewhere between 280 and 200 nanometers to actually kill pathogens. Next slide. As we look, how does UV radiation get produced? By passing an electric current through a gas, usually mercury, vapor, and it can be either via fluorescent lamp or a xenon arc lamp. The kind that's used most commonly is UVC, which is continuous, meaning the system delivers specific doses of radiation to kill bacteria, fungi, and viruses. Another is the pulse xenon system that emits UV in short, very short pulses. So this UVC, as you can see, this is where you want to be for the most efficacious killing. There are precautions. You must avoid contact with your skin and eyes, and ultraviolet disinfection is usually used in vacated rooms, radiology suites, and operating rooms. Next slide. This is a graphic showing the different devices. So this is a single tower device, the Spectra device on the right, as well as the bottom. And these mobile devices emit energy at 254 nanometers to reduce microbes on surfaces by 1 to 5, and sometimes even higher log reductions. The energy delivered depends on the device, the cycle time, and the organism. And microbial reduction is highest when the surface is in direct line of sight of the device. And that's an important concept to understand. If the surface is received indirect light from the emitter, it is less efficacious. So this central system with the 3 towers is the surface-side system that I have done my research on. And it's important to understand that energy delivery is really based on the law of physics. So if you double the distance from an emitter, from 1 to 2 feet, the energy is reduced by a quarter. And this is important as we look at the next studies. The more emitters you have in a room at one time, the more and better the kill is going to be. Next slide. In this study by John Boyce, he looked at the impact of the room location on UVC irradiance and dosage and antimicrobial effect delivered by a mobile UVC light device. In this study, there were 6 UV light sensors, which actually determine the irradiance. How much is coming out of that machine to this set spot? And then the dose is then also determined when you add up all the irradiance readings every second during a cycle. So in this study, there were varying distances, varying orientations relative to a single UV device, but with sensors at different locations. There were also stainless steel discs inoculated with MRSA, VRE, and C. diff spores, and they were placed right near the sensors, and that way they could collate the log reductions of bacteria at 15-minute cycles, which I will share, and controls were not exposed to UVC. The light sensors were at different distances, 4 feet versus 10 feet, as well as 2 different orientations, vertical or horizontal, relative to the distance. And I'll share the results. The energy delivered is affected by the distance from the device and varies substantially based on the surface orientation in a room relative to the device. Next slide. Looking at this graphic, okay, let me orient you first to the top graph, top photo. Black bars are ICU rooms in this study, and gray bars are standard surgical rooms. This top bar looks at the irradiance. 4 feet direct on the left, shaded 10 feet on the right. You can see substantial differences in output. Now, in the bottom graphic, and we'll just focus on the 4 feet direct because they don't all line up perfectly, but 4 feet direct, under 4 feet direct. What we're looking at in this bottom graphic with the pink and white and hot pink dots, let me talk about those. White, light pink, and hot pink, the hotter the pink, the more and stronger the dosage that is delivered. And you can see 4 feet direct, 770,000 microwatt seconds per centimeter squared. We also talk about that in terms of millijoules. And when we have 10 feet shaded all the way over on the right, and it's lined up nicely, you can see we have 8,900 microwatt seconds per centimeter squares, or another word is millijoules. So by varying the distance, 4 feet versus 10 feet, a lot less of the dosage was delivered with the 10 feet. When we also think about shading, here we have in this top 10 feet direct. We also have 10 feet at an angle, and you can see that in this 10-foot direct and 10-foot direct, looking again at the actual millijoules that were delivered, less with the less distance, okay? So having shadowing, if we look at this 4-foot zero angle, you can see that we're still getting kill 150,000 better than the 10-foot shaded, but still not the same as 4-foot direct. Next slide. When he looked at the killing, I'll just focus on the 15-minute numbers. You can see high energy delivered, MRSA, VRE, C. difficile with pretty significant log reductions, as opposed to 4 feet with shaded areas, 3 and less C. diff killing for sure, as well as VRE. So, important point with respect to UV, shaded areas receive much lower doses than surfaces in direct line of sight for a single cycle. Spores are tougher to kill, and that's important. As well, some of the manufacturers may recommend running more than one cycle in a patient room. However, next slide, with the Surficide system, we use 3 towers all in one room at the same time. And that minimizes shadowing and delivers more energy in less time. And it reduces the distance to the surface to maximize the intensity of one cycle. So in the study that we did in one of our rooms, next slide, you can see we put 2 emitters in the bathroom, and we had coupons inoculated with C. diff, MRSA, VRE, Acinetobacter, and CRE. Next slide. You can see we, in black is MRSA, A. baumannii, C. diff. We had excellent reductions with less than or 33 minutes in the room. So this is really important for the nightmare bacteria, CRE. We had substantial dose reductions. And this is very efficacious. Just a word as to how we use the Surficide system for those patients that have C. diff. We put the emitters, 1 emitter in the bathroom every single day and let it run with the door closed. And then we use, once the room is terminally cleaned and finished, we pull that emitter out of the bathroom. We have 1 emitter on either side of the bed and the foot of the bed, and then zap the room. So the prior occupant whatever was there is, for the most part, we hope, killed. Now, in this study that we did, we looked at a number of different sites in the room: the overbed table, the toilet seat, computer keyboard, bathroom doorknob, etc. And we did cultures post-bleach, and then we followed that with post-UVC. So we cultured the rooms post-bleach, either less than 10 colony forming units or greater than 10 colony forming units. And if it was less than 10, that meant it could be 0 to 9 CFUs. And you can see in the post-UVC, we had one keyboard that had 10 colony forming units of C. diff on it, and all the rest had less than 10 colony forming units. Looking at another pathogen, the MERS coronavirus, that was the emerging pathogen in 2012, associated with acquisition with camels in the Middle East, hence the Middle East coronavirus. The surficide system was also studied at a University of Iowa lab, and in 5 minutes, there were 5.9 log reductions of MERS-CoV compared to the controls. Next slide. In the final study, I'm going to share a comparison of the efficacy of multiple UV light systems in a radiology suite. The study was done by Jen Caddenham and as well as Dr. Donsky's group. In order to evaluate the efficacy of 8 different UV decontamination devices, they used 4-minute UV cycles to assess recovery of MRSA, VRE, and C. diff spores on steel disc carriers at 5 sites of a CT head scanner. So the foot, the body in the graphic, and 3 sites at the head, where the head would have been resting and touched by many of the workers positioning the patient. So they looked at 4 standard single tower UV devices, akin to some of the single devices that I showed you on one of the earlier slides, and they had similar performances with 2 log reductions of MRSA and VRE and about 1 log reductions in C. diff. The pulse xenon device resulted in much less reduction in pathogens, I will share the next slide with these results. So we have the 3 vertical towers, which was the surficide system that we're talking. The top graphic was MRSA, VRE, and then C. difficile. The bottom graphic, there's 3 vertical towers, and you can see the performance. And you can also see the not so good performance of the pulsed xenon device, which when they did the irradiance evaluation, and now that you're pros on the electromagnetic spectrum, they were actually shown to be in the UVB range and UVA range, which was not as efficacious for the kill. So what is the future of UV light disinfection? Well, in the New York Times just a couple of weeks ago, they're doing a number of studies on far UV. That's not going to the right where UVA and UVB is, but lower, that potentially shorter, higher energy wavelength can be used to treat a room continuously. As I mentioned, the rooms are vacated when we use ultraviolet disinfection. There are some studies ongoing now with mice to assess them for adverse effects when there is far UV, which is shorter wavelength. Continuous non-chemical cleaning of air ducts and other HVAC systems have been used in the top right graphic that are installed in the HVAC systems. And the surficide system is partnering, looking at UV disinfection in ceiling devices, for keyboards specifically, and for cell phones. So in conclusion, environmental cleaning alone is rarely optimal. Many UV studies have shown vegetative organisms are easier to eradicate than spores. Varying the orientation and distance from UV emitters determines the actual amount of energy or killing to that surface. Less distance, better killing. All UV devices are not equal. So infection control programs really must focus on the basics: hand hygiene, appropriate isolation, meticulous cleaning and disinfection, and antimicrobial stewardship as the tenets of keeping our most vulnerable populations safe. And I will end with a question. If you have any questions, you can ask me and send me an email, or a question and a point to ponder: as a long-term care facility, does your nursing home provide job-specific training and competency checks with ongoing annual feedback to your environmental services personnel regarding the quality of their cleaning and disinfection? And I'll turn it back to Megan.
And now, for anyone interested in learning how direct supply can help you navigate these new technologies and products, please help me welcome Karl Seagren, our dedicated product consultant.
Thank you, Megan, again, and thank you to all three of our presenters. Lots of fantastic information. I learned a lot, and I'm going to save this and go back and rewatch this material as these topics come up frequently as I'm talking with our customers on a regular basis. So thank you again to all three presenters. As Megan said, my name is Karl Seagren. I'm a product consultant for environmental solutions here at Direct Supply. With more than 1 million products in our offering, we do offer the broadest selection in senior living. And this includes all the essential items for your infection prevention and control program, from popular brands like Evaclean, Clorox, Lysol, Gojo, and many, many more. Over the next few minutes, I'll just call out a few of those that focus really more so on enhanced disinfection tools, as well as some of the more innovative products and services that we've added over the past few months to help you stop the spread of infection. So as you look to reopen your communities, there certainly are no doubt more concerns on your mind than there have been probably in the past. And we're here to help with all the products that you need. Things like thermal temperature scanners, touchless thermometers, and safety barriers, separation barrier products. All these products that are designed really to keep COVID-19 and other infections out of your communities and to help keep them contained if they are already there. And as our speakers discussed, there are many tools available to help you to provide an extra layer of protection in the fight against not just COVID-19, but all other infections. As Dr. Mangino just explained, UV light emitters are great at killing almost all pathogens that enter their light. And I learned today some areas of shadow as well. Key advantage of UV is that it does not require the use of chemicals, so you don't have that ongoing expense. They are available in both manual and robotic form for full room disinfection. And we also carry some disinfection chambers that use UV light to disinfect small items like cell phones, tablets, and other smaller medical devices. Another popular tool used for enhanced disinfection are misters. Misters are used to spray a fine mist, as the name would imply, of water droplets that can provide an effective coating over all surfaces where they're sprayed. They can really use a wide variety of disinfectants typically, and while you will have that ongoing expense of chemicals, the initial capital investment is typically going to be quite a bit lower than with UV. And last but not least, electrostatic sprayers like the Evaclean Protexis sprayer from EarthSafe that Jeremiah spoke about take the benefits of misting really one step farther by adding an electrical charge to the water molecules that the sprayers emit. And that electrical charge creates a magnetic attraction between liquid droplets and the surfaces that the droplets are sprayed on. And this leads to an even more thorough coating on virtually all surfaces in significantly less time than with traditional disinfecting methods. At the end of the day, though, really using some form of enhanced disinfection is not only going to make your communities cleaner and safer, but it's also going to provide additional peace of mind for your residents, their families, your staff, and any guests that enter your communities. I do want to call out, though, that due to the massive worldwide demand right now with products like misters and electrostatic sprayers, there are significant lead times, quite honestly, several months at the moment. In the meantime, fortunately, we do have the ability to help you maintain a high level of building safety and health. Our TELS Building Services now offers sanitization, disinfection, and deep cleaning services. And while we initially envisioned these services really more so for terminal cleaning and restoration, we have found that many senior living providers are utilizing TELS to support common area disinfection due to COVID positive residents, or to simply offset those labor costs that caused by the more frequent deep cleaning and disinfecting that you're doing today. To request a quote for any of these services, simply reach out to your direct supply account manager. Additionally, some new products that we have brought on board are related to shoe cleaning that can help disinfect the bottoms of your shoes. A disinfecting boot wash station and a walk-off entrance mat featuring disinfecting and drying zones that allow you to use the disinfectant of your choice are some cost-effective tools to cut down on the spread of pathogens that might be traveling on the bottoms of your shoes. And a more advanced product looks like a stand-on scale, and it uses UVC light to disinfect. So a person simply stands on the foot symbols on the scale. They can be wearing shoe covers or their regular shoes at the time. They stand on those foot platforms for as little as 8 seconds, and that machine is going to emit the UVC light to disinfect the soles of their shoes. Certainly, as we've just discussed, cleaning and disinfecting surfaces is very much top of mind and has never really been more important than it is today. At the same time, the need for healthy indoor air has also never been more critical. New research is coming out every day, and I'm sure you all have read and are hearing news articles on this that point to, and as Jeremiah alluded to earlier, point to the fact that the pathogens like the SARS-CoV-2 are transmitted not strictly by respiratory droplets, but also by airborne transmission. And the same can be said for influenza. So that simply goes to proof for everyone that the standard ventilation and filtration methods that we have been using in the past really are not sufficient to help rid the air of these infectious diseases. As that realization that indoor air quality can impact not only the spread of these types of infections, but also the general health of residents and staff, many communities are investing in tools that can help them to maintain healthy air. One such tool that we've recently added to our offering uses needlepoint bipolar ionization, which is able to address both droplets and particles. And it does this by removing life-sustaining hydrogen from the molecules to effectively inactivate pathogens. It's a great tool that Direct Supply is actually installing on our campus this month to protect the employees' health around our main campus and our Innovation and Technology Center as well. And we continue to add additional indoor air quality products to our offering to make sure that we're providing the greatest air purification products and systems to keep your communities healthier going forward and to limit the spread of infection. Last, but certainly not least, no infection prevention and control program really is going to be complete without personal protective equipment, hand sanitizer, and janitorial supplies. Our supply chain team is working diligently to keep the supply lines open during these times of crisis with major supply shortages. Our supply right now of 3-ply masks, KN95s, isolation gowns, face shields, and goggles is quite strong. And we continue to work hard to source the other essential pieces of PPE that we know you need. Additionally, we do have a steady supply of hand sanitizer that meets CDC guidelines and a new eco-friendly disinfectant that is on the EPA list and with just a 30-second kill time for COVID-19. It also happens to have a 24-hour residual efficacy on hard surfaces. So very excited about that product as well. For more information on all these products and services, simply head to Direct Supply's website. You'll be able to find helpful industry resources on COVID-19 and infection prevention. You can certainly check out product availability, and as always, you can place orders. If you have questions on any of this stuff, please reach out to your Direct Supply account manager with questions. Thank you very much for joining us.
An extra big thank you to Dr. Morales, Dr. Mangino, and Jeremiah Gray for all your time today, and have a great day.